I'm going to start, so I've been assigned by John to talk about the enlarging role of immunotherapy for melanoma and advances in the therapy of advanced melanoma and those in the adjuvant setting or in the preventative setting in patients with operable disease. Next slide, please. So this is my outline. As I said, it's first we'll start with metastatic disease, immunotherapy for stage 4, and then move on to the high-risk disease, immunotherapy for treating these patients. Next, please. Stage 4 disease, as you know, this is a stage where the cancer has already spread into the organs. So it's not only here at the primary site, it will into the lymph nodes, the lungs, or maybe the liver, or sometimes the brain. So this is the advanced stage of disease. Next, please. The options that we have, and Hussein has already talked about these as options approved by the FDA, are chemotherapy with Dacarbazine, approved more than 40 years ago, limited activity for these patients. Immunotherapy with high-dose interleukin-2, and the new drug Ipilimumab or Yervoy, and vemurafenib or zelboraf that Hussein has discussed already. Next, please. So this is, in a perfect world, there's a complete separation between the body, the normal cells, and the outside invading kind of pathogens or cancer cells and so on. So everybody would be happy and all have no disease. But obviously this is not the real world, and we're in the real world we're all under a constant invasion from all kinds of pathogens, whether it's the flu, chickenpox, etc., and cancer cells. And this is where the role of the immune system is central in protecting us and preventing or fighting these diseases. Next, please. So what is the immune system? It's from the Latin term immunus, which means exempt, referring to the protection against foreign agents. And the definition from the dictionary, it's the integrated body system of organs, tissues, cells, and cell products that differentiates self from non-self and neutralizes potentially pathogenic organisms. Next, please. And one of the leading hypotheses of why cancer develops is, and why does it escape, the recognition by the immune system, is the so-called immunoediting hypothesis. In healthy people in normal conditions, we have this state of elimination. The tumor develops, it gets fought by the immune system, and it's eliminated. But what happens is that some of these cancer cells, they start mutating and developing or releasing certain factors and certain changes. So try to outsmart the immune system and develop a state of equilibrium. Now we have the more tumor cells being proliferated and produced until it eventually escapes the immune response, and now we can detect the cancer. And this is where the role of immunotherapy plays, is try to reverse this succession of events back into equilibrium and hopefully back towards elimination and cure. Next, please. So I'm going to start with high-dose interleukin-2, IL-2, which was approved by the FDA in 1998. So IL-2 is a factor in the blood that is produced by the immune system cells that plays a central role in regulating the function and growth of certain principal cells in the immune system. This was tested in the laboratory and shown to have anti-tumor effects at high dosage, and therefore brought to the clinic. Next, please. And this is now in the clinic. This is how it was tested. Interleukin-2 patients go to the hospital for 5 days. They get really sick. It's a toxic treatment. 5 days of treatment. They get a rest period for about 2 weeks. Come back for another 5 days of treatment. Next, please. And the studies that were done with high-dose IL-2. This is the kind of the end result. This slide shows the response durations with patients undergoing IL-2. Here, it's the overall response rate. The percentage of patients who have a tumor shrinkage from IL-2 therapy is only 16%. Out of these, 10% are partial responses, and 6% are complete responses, complete kind of shrinkage and disappearance of the cancer. What's important to learn from this slide is that looking at these 6% of patients, these are all durable responses that on the latest follow-up, they go on for about, the majority of these go on for about 10 years or more without disease recurrence. And this is the hallmark of immunotherapy, is the potential cure and the glimpse of cure that we first see with this kind of treatment with IL-2 and earlier with interferon alpha in the adjuvant setting. So are we doing something about it? Yes, we are. Try to build on the success of IL-2, make these 6%, maybe 10%, 15%, or 20%. And this brings us to this factor called VEGF, or vascular endothelial growth factor. This is a factor that from the early stages of development of the tumor, it is involved in the process of angiogenesis. In other words, we have tumor cells that are developing. They don't have blood vessels that support them. They start releasing factors such as vascular endothelial growth factors, which is one of the key factors in this process, and then develop these sprouting blood vessels that are now supporting the tumor and maintaining it. So this is the central role of VEGF. Next, please. What we've learned recently that VEGF not only supports angiogenesis, but also has a central role in immune suppression. So there appears to be this relationship between immune suppression and angiogenesis, and where this vascular endothelial growth factor is a key factor. Next, please. One study that looked specifically at patients treated with high-dose IL-2 have found that patients who have high VEGF, high levels of VEGF, are unlikely to respond. So R is response, and R is no response. So patients who had low VEGF had a response, and high VEGF, no response. None of the high VEGF patients responded to interleukin-2. Also, when they looked at survival in patients treated with IL-2, those who have low VEGF have much better survival than those who have a high VEGF. And this led us to the hypothesis that probably if we can reduce VEGF in the blood, we can increase the percentage of patients who may be responding to IL-2. Next, please. And we have such an agent. It's an agent called VEGF trap, or aflibercept, which is a soluble receptor that basically essentially sucks VEGF out of the blood and depletes it to low levels. Next, please. And we've done a study that we've recently, our group published at the Clinical Cancer Research Journal. We've seen significant clinical activity of this agent, VEGF trap, as monotherapy without any other agent. And therefore, we decided to take it forward. Next, please. And this is now one of the ongoing studies in our center, which is combining aflibercept with high-dose IL-2 versus high-dose IL-2. It's a national study that we're leading it from here, from Pittsburgh, and hopefully building on this promise of IL-2 in melanoma. Next, please. Next, I'm going to move on to Ipilimumab, or Yervoy, which is the drug that most of you, I'm sure, have heard about, recently approved by the FDA for melanoma. So it's a new drug. It's a new mechanism of action. Basically, not your father's monoclonal antibody, and I think Lou and I'm sure know this from the side effects. It's a new hope, definitely, for melanoma patients, and most importantly, unique new class of toxicities that require special attention and special management. Next, please. So how does Yervoy or Ipilimumab work? Now, these are two cells. Think about this cell as the quarterback and this cell as the offense. Okay? So the quarterback, which is so-called antigen-presenting cell, takes a chunk of the tumor, the white thing here, and presents it to the T cell, the offense, which is basically this is the cell that attacks the tumor. So it teaches the T cell that this is a foreign antigen, this is a foreign protein. If you see this on a cell, you need to attack it. And then it gives us another boost, kind of acceleration, by stimulating this so-called CD28 receptor, and now we have an active T cell. This T cell first recognizes the tumor, it knows the tumor, and it is fully active. Next, please. But what happens in normal conditions, when a T cell becomes fully active, you have a break. You don't want T cells to be active all the time, because you're going to end up with autoimmune diseases, all kinds of abnormalities, and therefore, but normally, by nature, we have this break, the CTLA4, that goes up and inhibits the T cell. So you have a T cell that knows the tumor, it is fully active, but now it's being inhibited by CTLA4. This is good for other normal cells, but not when we have cancer, because now it is mediating tolerance to the cancer. And this is where the Ipilimumab role comes. It is a monoclonal antibody, basically a targeted antibody that can target the CTLA4 and prevents its binding to this protein on the quarterback, and therefore the offense or the T cell is now fully active again, and it knows the tumor, it can attack it. Next. And this is another way of looking at it. So basically, when the tumor when the antigen is presented to the T cell, it turns on the ignition, And then when it binds, we have the activation of the CD28. This is acceleration. But then when you hit the CTLA4, you're braking. So you have this balance between acceleration and braking. The problem is that when you remove the brake completely, if you're driving downhill, you may get colitis, you may get these bad side effects that we're going to talk about in a minute. Next, please. So two large studies were tested in patients with melanoma, testing this drug called Ipilimumab. The first study was first reported was a second-line study. So these were patients who had treatment before, so prior treatment. And the other study was a first line. These are treatment naive, stage 4, no treatment before, and that were both reported as positive and led to the approval by the FDA. Next, please. So the second line study, which essentially led to the approval, was Ipilimumab plus a vaccine, a melanoma vaccine, versus Ipilimumab plus placebo versus this vaccine alone. There was this hypothesis that if we give a vaccine with Ipilimumab, it may make it work better. Now, it turned out not to be the case, but this was the essential hypothesis, the way they tested it. Next, please. Now, this study was positive, and what we learned is that the Ipilimumab arms, with or without the vaccine, were superior to the vaccine alone. Patients lived longer. Even when we look at 1-year survival or 2-year survival, patients with the Ipilimumab lived longer. Now, the vaccine did not add anything in terms of activity for Ipilimumab. Next, please. Now, and obviously now when we have this, the brake, we take our leg off the brake and we have overstimulation of the immune system, we end up with these autoimmune adverse events, right? So we have the skin toxicities, rash, gastrointestinal toxicities, diarrhea, colitis. We have pituitary, these endocrine glands that are less, not functioning appropriately, or liver inflammation, or that are serious events that what we need to do with these is recognize them early on and initiate systemic treatment, whether it is steroids or other immunosuppressants, at the earliest stages to prevent progression into more advanced disease. And the essential thing that's important in this case is patient-physician communication. So the first glimpse of a rash or a diarrhea or a fatigue or abdominal discomfort is to contact the physician, let them know, and see whether we need to do blood tests or we need to do additional imaging studies, and whether we need to initiate steroids and so on. These can be managed if we can catch them early and manage them successfully. Next, please. And this slide essentially summarizes the adverse events or the side effects that were noted during this study. And again, we see the skin rash, the diarrhea and the colitis, inflammation of the colon, the bowel, the endocrine gland dysfunction, the liver inflammation, and even death was reported on this study. It can be challenging sometimes to manage these adverse events, especially if we don't catch them early, but in some patients, even if we catch them early, sometimes it may lead to fatalities. So these are serious and need to be dealt with appropriately. Next, please. The other study, which tested Ipilimumab now at a higher dose, so the first study was 3 milligram per kilogram, which is the currently approved dose. The other study tested 10 milligram per kilogram. There's some data that it may be better than 3. We don't know yet, but also maybe a little bit more toxic, actually. So it combined Ipilimumab with the chemotherapy drug Dacarbazine versus Dacarbazine alone. Next, please. And what we've seen is, again, there is superior clinical activity in terms of survival for the Ipilimumab group versus the chemotherapy alone group. Next, please. And when we look at survival, it's the same thing. That's the 1-year survival, 2-year survival, 3-year survival. So this is Ipilimumab, this is chemotherapy, chemotherapy. And this was also a factor in approval of the drug. Now the FDA approved the Ipilimumab or Yervoy at 3 milligram per kilogram, just because there is no data to tell, at least at this point in time, that 10 is better than 3. And with 10 potentially being more toxic, the decision was to approve it at 3 for only 4 doses. Next, please. So moving into the realm of combinations, what our team is doing in terms of taking this forward is working on the combination therapy. So T-cell activation, we know, requires both an antigen stimulation and relief of the inhibitory signal. So we need to turn the ignition, and we need to take our little bit of the break. Now, combining anti-CTLA-4 with interferon alpha, which we had experienced with Dr. Kirkwood, led major studies in the adjuvant setting. That was the first that potentially can cure this disease or given at an earlier stage. But we know that interferon alpha can stimulate the quarterback, the dendritic cell, and help them take up and present more antigens from the tumor to the T cell, and it also can co-stimulate the T cell. So why not take it and combine it with anti-CTLA-4? Next, please. And this is how I wanted to look at this, but basically what I'm trying to say here is that you have this tumor which is pushing the immune system towards immune suppression and immune tolerance, and you have agents like interferon alpha that may push it or repolarize it into another direction, which we may have actually effective cell-mediated anti-tumor immunity. In the middle, we have agents like CTLA-4 and others who are trying to maintain a balance. They don't want things to move this way or this way. But if we have cancer, this may be not helpful, not that much help. Next, please. So the goal is to combine interferon alpha with anti-CTLA-4, and that's what we did. Next, please. So our study, which used another agent called Tremelimumab, it is similar to Ipilimumab. It's not approved by the FDA. We tested it in a clinical trial. And what we know from Tremelimumab is that the response rate is 7% in this population. Our response rate was 24%. We had mostly durable responses. This patient here is, these data were updated a year ago. So he's at least 49 months plus, without cancer recurrence. And so we had an improvement across multiple levels, and what we decided is to take it nationally. Next, please. And this is our study soon to be activated, which is combining now interferon with ipilimumab at 3 milligram and 10 milligram. As I said, we don't know which one is better, so we felt it's important to test it in this study. So patients get the combination versus the ipilimumab alone, combination ipilimumab alone, and hopefully we get our answer in about a few months. Next, please. Next, I'm going to move to the high-risk disease. So these are patients, not stage 4, or potentially could be actually stage 4, but resected. So they have no evidence of cancer. They present with a big tumor that was surgically resected, but have at least 40 to 50% or more risk of recurrence and death. So how to reduce this risk? Next, please. So stages, these are stages 2B and 2C initially, which is tumor. It's in the skin, but it's deep, or it could be ulcerated, right? Next, please. Or it's a stage 3. So these are patients where the tumor starts on the skin, then invades the lymph nodes, right? When we go into these lymph nodes. So it's still regional involvement, but can be surgically resected, still at high risk of recurrence and death. Next, please. So what Dr. Kirkwood led these 3 national studies that have shown that for the first time that we have a drug that may potentially cure this disease when given at earlier stages, and it had reduced the risk of disease recurrence as well as the risk of death from this disease. It was approved by the FDA in 1995, 1996, and it is the standard of care. Next, please. What recently has been approved by the FDA is a drug called pegylated interferon. This drug was tested by the EORTC, European Organization for Research Technology, and so on. I forgot the actual thing. But basically, patients were with stage 3 melanoma, lymph node involvement, were classified into 2 groups. One group had microscopic involvement of their lymph nodes. So they had the lymph node taken out after a sentinel lymph node procedure, or had palpable lymphadenopathy, large lymph nodes. So these were 2 groups now kind of included in this study, and they were either observed or given interferon, pegylated interferon in this case, up to 5 years. How is pegylated interferon different from regular interferon? It's given as an injection once a week, so it is longer acting. The dosage differs a little bit from what we give in the regular high-dose regimen given over 1 year. They are slightly lower. Next, please. The results of this study, first presented in 2007 and updated last June in Chicago, was that we can improve recurrence-free survival. So we can reduce the risk of this cancer coming back by about 18%, as first presented in 2007, which was now updated with longer follow-up and more complete data to 13%. So it is 13% reduction in the risk of cancer recurrence. When they looked at survival, the patients lived longer. They did not see a difference between the pegylated interferon group and the observation group. Next, please. Now, when they looked at these two groups, we said there is the microscopic disease involvement. Those are at sentinel lymph node, and those who are bulky. So for the microscopic group, lymph node involvement, there is an improvement in recurrence-free survival. It was about 27% in 2007, 18% reduction in the risk of recurrence in 2011. So this is now the final what we know. But no benefit in terms of or no difference noted in terms of overall survival between pegylated interferon and observation. Next, please. When they looked at the N2 group, these are the bulky lymph nodes, those who become with a palpable lymph node and undergo surgery, there was no difference in any other, in any outcome. Not recurrence, not survival, or anything else. Next, please. In terms of toxicities, it's the usual toxicities. And those of you who had experience, or your family members had experience, the toxicity of interferon, the fatigue, the flu-like symptoms, the liver toxicities, the depression sometimes, and so on. So this is the same kind of toxicities. What was interesting that the central hypothesis for that study is that it was planned to be given over 5 years. But on the majority of patients actually got it for a little bit more than a year, and only 23% went on to receive 4 or 5 years, which says that that's because patients could not tolerate the toxicities longer than that. Next, please. So what's the future? Is this study that again it's our group leading from here. It's an international study. For patients with high-risk melanoma. These are the highest risk, so these are the stage 3 and the high risk of stage 3, 3B, 3C, as well as stage 4, but that is still operable. Somebody with a lung nodule that we can remove and then do a scan and see no other evidence of disease can go on this study. And it's basically building on the success of interferon and looking into the new promising agent, which is Ipilimumab. So patients on the study are randomized into Ipilimumab at 3 mg or 10 mg versus the standard of care. It has an accrual goal of about 600 patients. We have about 340 patients so far. Next, please. And where are we going from here in the adjuvant setting? It also actually applies to the metastatic setting. Most of you probably, most of you have volunteered to give us blood and give us tissue to do research. And some of this research is focused on biomarkers. Can we look into those prognostic biomarkers that in a blood test or on a tumor tissue test, where we can classify patients into those who are the higher risk of recurrence and then treat them, or those who have lower risk of recurrence and then save them the toxicities? Or can we come up with predictive markers that can tell us that this is the patient who will respond to Ipilimumab and therefore treat this patient, or this is the patient who's not going to respond and therefore save this patient from treatment? And next, please. And these are some of these studies that are focused primarily on biomarkers. This is a study that I have friends in the audience that have volunteered to participate and have done great in this study. We're getting patients who come in with a bulky lymph node. We ask them to give us a piece of tissue at baseline. We give them treatment, then do the complete surgery 6 weeks or 8 weeks later, and give them more treatment with Ipilimumab. It has therapeutic intent to prevent the cancer from coming back, and we're interested, we're actually excited about the results that we're seeing, but also gives us access to tissue, to the tumor, where things happen, where we can look for these biomarkers or these signatures of biomarkers, and also take blood samples that you volunteered to give us, and also look at these biomarkers and try to come up with these signatures that can hopefully allow us to know what patients need to be treated. Next, please. And the sequel to the study is the next study, building on this story of interferon, is taking the tumor biopsy, giving interferon plus Ipilimumab, do the surgery, give them the combination after surgery, and hoping that we can actually have more success than even the prior study expected. And where's the future is going? Obviously, we talked about the break, we talked about the quarterback, the fence, and the receptors in between, but it's much more complex than that. And we're lucky that we're getting to learn more and more, deepening our understanding of the immunology of this of the patient and the biology of the tumor, and trying to find out new targets that can be targeted with immunotherapy, such as PD-1, which appears to be a very promising agent now after Ipilimumab, and we have now antibodies that can target OX40 or 41, these other receptors that appear to be key as well in this interaction between the host and the tumor. Thank you. Finally, I'd like to acknowledge obviously our patients and their family members who volunteered to be part of our clinics and our studies. Our leader, Dr. Kirkwood,